In September, we talked about what we might expect as we moved into the respiratory illness season here in British Columbia. We're now in that place, as expected, and the respiratory season is unfolding as we expected it would. But we are in a very different place than we were a year ago. And that is largely because we've done a number of things. We started to move again, to travel internationally, to travel globally, to travel across the country, to travel within the province. And we are seeing the return of common respiratory viruses that have been mostly absent in the last 2 years. We know that the three main viruses we need to pay attention to and be careful about are now COVID-19 is into that mix, but also influenza and RSV, and there are a number of other respiratory viruses that have been causing illness, and I'll be walking us through that now. Our focus throughout this pandemic and in every respiratory season prior to the pandemic has really been about protecting people who are at highest risk of severe illness or death, protecting our healthcare system, our capacity, and we know that's been stretched for many reasons, not the least of which is respiratory illnesses, and keeping our communities, our families and our communities safe and functioning for all the other important things that we need to do, which includes bringing people safely back together again. So I'm going to start with talking about where we are today. Only about 51% of eligible children have received their first dose of COVID-19 vaccines. And I'm going to show some data about why we need to pay attention to that. A year ago, we didn't have vaccines for children. We now do. And that's an important piece of protecting children from a virus that we know doesn't cause severe illness in most children, but can. And we know that children can also be part of transmitting it within households and families particularly. We know that over 86% of people 5 and over have received at least 2 doses of COVID-19 vaccines, and that is great. That means that we have a level of immunity that is higher than we've ever had, and that we know that that gives us longer-term protection against severe illness, even in people who are who have immune-compromising conditions and in older people. And most importantly, we also know that a large proportion of British Columbians have received a booster dose, and the fall booster is incredibly important right now. We now have more protection against severe illness because of this, because of vaccination, but also as we presented in September, we also have infection-induced immunity. And we have treatments. We have treatments for COVID-19, including Paxlovid, and we have treatments for influenza, including oseltamivir. So we know from the seroprevalence that about 90% of people in British Columbia have built some immunity to the virus through vaccination, through infection, or for many people, both. But we are also learning that our immunity is complex, and I've talked about this many times. We have that short-term protection with antibodies in our blood that respond when we're exposed to the virus, and we know that those antibodies protect against getting infected, having that virus cause infection in the first place. But we know that whether those antibodies are from previous infection or from vaccine, they do go down over time. And usually that's around somewhere about 3 or 4 months, we start to see a decrease in that protection against infection. But as we've talked about many times, we know that that longer lasting second part of our immune system, the memory cells, the cell-mediated immunity, last much longer and give strong protection against severe illness, hospitalization, and death after 2 doses, but also that gets boosted up when you have a booster dose. So the combination now of immunity from infection and vaccination and the combinations that we've seen, and it is complex. People have had 2 doses and 1 infection, or 3 doses and an infection, or several infections and then vaccination. And all of that builds a complex picture of immunity that makes it challenging for us to tailor who needs what. What we do know is that right now it's really important for people to get that booster dose to protect us all from infection and help dampen down the transmission of COVID-19. And we know that the combinations we've seen mean that most people in BC are no longer at risk of severe illness and hospitalization, even in long-term care, even people who are immune compromised. And that is really important. So what are we seeing right now? In terms of hospitalizations and deaths, as you know, our testing now is focused on people who will need potentially need treatment or may end up with more severe illness. And so that's not a reflection of the amount of transmission that's happening in our community. But what is important is following the people who have severe illness. And as we've seen in the last few weeks, our hospitalization rate has actually started to come down, which is good news. The daily deaths, as we started back in April, reporting on all-cause mortality at 30 days, that has trickled along and is also coming down slightly. We know that the cause of death, the underlying cause of death being COVID, is only about 40% of those. And I'll have a bit more information about that. So if we look at hospitalization rates by age, we all along in this pandemic, we have seen that it is older people that are more likely to get severe illness, more likely to be in hospital, and more likely to die. And thankfully, with the booster dose program that we've started and focusing on primarily making sure that people who are older get that dose, we have now started to see decrease in hospitalization in particularly people over the age 80, which is the highest risk group for COVID. Our 30-day mortality, as you know, as we get the underlying cause of death data from vital statistics, we see that about 30 to 40% of people who die with a positive COVID test, COVID is one of the reasons why they've died. And that's remained relatively steady through the last several months. If we look again at hospitalizations and we standardize it by age, again, clearly we see that anybody, compared to the same age person who's non-vaccinated, people who are vaccinated with at least 2 doses have half the rate of hospitalization, critical care, or risk of dying. And the same, and that again, it's 4 times higher if we look at people who've had at least 1 booster dose. Really important to remember that this makes a difference. This makes a difference for your own personal health, but it also makes a difference on your risk of ending up in hospital or passing it on to others. The most prevalent lineages, as you know, through this whole pandemic, we've been doing whole genome sequencing to help us understand what is being transmitted around the community in British Columbia. And there's a whole large gray part in the most recent ones. So this is when Omicron, the pink and purple are Omicron, and the purple, different shades of purple, are basically BA5. And as we have reduced the amount of PCR testing we're doing, there remains a whole bunch of others that we need to look at. But we have been sequencing those others, and this is what makes up that gray box. As you can see, it's a whole variety of slightly different mutations, but all of these are Omicron BA5. So that's really important. And we've seen the evolutionary virologists have told us that we're seeing what they call a confluence, where there's not a new strain that's arising that's causing very different symptoms or very different transmission rates. What we're seeing is it's all different variations around the same sort of variant. And most of it is as a different variants of the BA5 with slightly different mutations. And so we're continuing to follow that really closely. It is unlikely, given what I've just talked about with our immune level of immunity that we have in British Columbia, that we're going to see something markedly different arise in the near term here in British Columbia. But we are also watching what's happening globally, because we know that globally that's where Omicron arose. But we would get some warning around if we started to see a different new strain arise outside of British Columbia or Canada. The other thing that we've been monitoring carefully is wastewater samples. And as you can see, we've seen a gradual decrease in leveling off. And it's been a little bit up and down over the last few weeks, but mostly low and stable. And these are the ones from the Lower Mainland. We have now expanded our wastewater sampling to the interior and island here, but we're still at the point of calibrating those. So it takes some time to get enough data points to be able to look at trends over time. But what we are not seeing is any dramatic increases in the amount of virus that we're seeing in wastewater samples here on the island or in the interior as well. And we're working on being able to do this in communities in the north. This is something that's outside of our testing parameters and changing and testing, and it helps us give a barometer of what's going on. The other things that we're looking at and trying to validate are being able to use these same samples to look at how much influenza or RSV we have circulating in our community. And these are relatively new techniques. It's not something that's easy to do, and so our lab is at the forefront of developing the ability to do that to help us understand other viruses that are in our community as well. So what else is going on in British Columbia? One of the things that we monitor over time, and this is all on the new dashboard that we're building on the BC CDC. So in the past, we've had our influenza surveillance bulletin that would come out periodically, and now we've moved it on to a centralized database where it's interactive, so you can go on that in the BC CDC website, and the link will be in the news and the briefing note. So one of the things that we have been watching over time is physician visits and community visits to healthcare practitioners, so physicians, nurse practitioners, for respiratory symptoms. And so this could be anything. This is a clinical diagnosis of what we like to call influenza-like illness. So it's anything that's causing a respiratory symptoms. And we can see that in December and January of last year, we had that big peak, and that was when Omicron first came in. And we're now starting to see a gradual and a more steeper increase within the last 2 weeks of respiratory illness in British Columbia. If we look at that and break it down by age, we see that that increase has been driven by respiratory illness in young people. And that should be no surprise. We've been seeing that in younger people needing ICU care and younger people going to emergency departments and seeking treatment across the province. One of the things that we see, though, is it's across all age groups. We know that school-age children are mixing more, but also younger children. And it's important to reflect on that, because there are things that we need to do to think about protecting younger children as well. If we look at what's causing that illness, especially in the last little while, we look at laboratory data that helps us understand what pathogens are causing illness. And this comes from swabs that are taken of people with influenza-like illness or respiratory illness across the province. And we do laboratory tests to look at a variety of pathogens. And what we can see is that for the last couple of months, one of the main causes of respiratory illness across the province has been enteroviruses and rhinoviruses. And those are ones that we call the common cold. And enteroviruses in particular can also cause some more severe illness. We've seen EVD, enterovirus D68, which is one particular strain of the virus that can cause more severe illness in children. And that has been one of the drivers of children needing hospital care or medical care over the last few months. In the last week and a half, we've also seen, you can see in a purple line there, that dramatic increase in influenza. And this is almost all influenza A, mostly influenza A H3 and N1, although we haven't figured that out yet, in particular, sorry, H3N2 and H1N1. What we've seen, though, is a leveling off of SARS-CoV-2. So that's not what's causing most of the respiratory illness that we're seeing right now. And we've seen an uptick in RSV, not the dramatic increase that we're seeing in influenza, but still an important increase. If we look at the BC Children's Hospital laboratory data, which is something that gives us an understanding of what's happening in younger people across the province, it's representative but not inclusive. And if we look at the upper picture has, the smaller picture has SARS-CoV-2 included. And then if we take that out, because that was the large proportion, we saw lots of younger people having Omicron essentially since January of last year. But if we take that out, the light green is RSV. And so we did see in BC a fair amount of RSV circulating last winter. And that's important to note. One of the concerns that we've had and that I've talked about is that we have several cohorts of young people who have never been exposed to RSV before, which which we're seeing in some parts of the country, particularly Ontario. We're seeing a lot of that, where RSV is causing not more severe illness, but because more children have not yet developed immunity to it, because they weren't exposed to it over the last few years, it's causing an increased numbers of children requiring hospital care. We're not seeing the same picture yet here in BC, though we're continuing to watch. We did have quite a lot of RSV circulating last fall, and we're starting to see it increase now. But what we're really seeing that's making a difference in this province right now in children is influenza, and influenza A in particular. So the other thing that so I'll just talk about through these quickly. So if we look at SARS-CoV-2 and at the Children's Hospital, we can see very small numbers and the percent positivity sort of bouncing around in small numbers. So it's not the main driver of what's causing people to need hospital care right now. RSV is increasing, and the percent positivity of the test is increasing. The number of children requiring the test has increased as well. But really where we're seeing the big increase in young people is influenza. And I say this to make the point, really importantly, influenza is a vaccine-preventable disease. We have good vaccines that work well in children. Children over the age of 6 months of age are eligible for influenza vaccine for free. There's also the nasal spray influenza vaccine that's available for children that's very effective. And this is a warning to us. We're starting to see influenza circulating. We know that children often don't get very sick with it, but some of them do. But they can also pass it on to others. So this is the time to make sure we're best protecting children by getting them vaccinated against this virus in particular. I want to just talk a little bit about, it's not possible now to tell if you have symptoms of COVID, influenza, enterovirus, RSV. They all cause very similar types of illness in most people across the board. But the actions we take to prevent the transmission and to look after ourselves are the same. One of the things that we've had in place for a long time is saying, if you have COVID, you need to stay home for 5 days. That's no longer relevant in the setting that we are in now. Instead, if you have symptoms of any respiratory illness, we recommend, the guidance is to stay home and to limit close contact with others until you no longer have a fever and you're well enough to participate in your usual daily activities. That's what we need to think about. It's the symptoms themselves. It's hard to differentiate if it's one or the other, and it doesn't really matter in terms of our risk to others. But we need to be cautious. We need to be cautious, and that means if you have any symptoms at all, even mild symptoms, wear a mask when you're around others, even in the home. And one of the things that where masks actually are more effective is when you're in close contact indoors with somebody. And we know that many of these viruses are transmitted within families, between siblings, between parents and children, grandparents and others, in those settings where we don't think about wearing masks. And it is, particularly if you have somebody who's more vulnerable within your household, or you have an infant, you can protect them by trying to keep people who are sick away from them as much as possible, and to wear masks in those settings. If you're sick at all, postponing non-essential close contact with people who may be at higher risk, or at higher risk of getting sicker with these viruses, so seniors, elders, infants in particular, and young children, and those who are immune compromised. If you can postpone those visits, that would be good, particularly bringing children in to visit people in long-term care. When there's a lot of viruses around and people have the sniffles, it's very risky that you can bring that into a higher risk setting. If you can't postpone those non-essential visits, then it is important to reduce the amount of time that you spend in the place, to wear a mask, and to take all of those other measures like hand hygiene, looking at ventilation, looking at whether you can do it outdoors, etc. We also need to avoid those social settings, especially indoors, where we may inadvertently spread to others. So move the visit outside, wear a mask. As I mentioned, think about not taking children along if there is illness circulating in their class or in the family. If you do have symptoms, but it's essential to be in close contact with others, then we need to use all of our preventive tools. So masking, washing hands, following respiratory etiquette, paying attention to space and distance and ventilation. And that goes for common spaces like workplaces, schools, to reduce risk of transmission. And I would like to take a minute to talk about masks and where they are most useful. Last year we had mask mandates, but they were not in isolation. It was in the context of what we were facing at the time, including severe illness in many adults, as the immunization was increasing, but not yet at the level that we needed. We had no vaccines available for children. We had adults who were getting very sick and putting pressure on our ICUs and hospitals. Plus, we had absenteeism of healthcare workers, and many workplaces outside of healthcare were working from home. We had gathering restrictions and travel restrictions and barriers and capacity limits. We had reduced activities in schools. And in that context, masks were incredibly important and necessary in a broad range of settings, including the structured settings like workplaces and transit and schools. We are in a different situation now, as I've mentioned. We have a very high level of immunity against COVID. We have both immunity through vaccinations for influenza and treatments. We have treatments for influenza, we have treatments for COVID, we have treatments for RSV. Masks still need to be available and accepted in workplaces, on transit, and other indoor settings. We know that we had last year, for example, restricted activities for children, and that had consequences for the way schools functioned and for the health and well-being of children. We have learned through this pandemic the critical role that schools play, not just for children, but for families and communities. And it is more than just education in a school setting, as we know. It's the physical, emotional, social needs that school communities provide for children and families. And we've pulled together in this province to ensure that we keep these essential environments open. And I really, again, our gratitude goes to all of the educators, staff, and parents and communities who made this a safe reality for our children. I will also say every single school in British Columbia has had a ventilation assessment, and we continue to make that a priority. We have a committee that is continuing to meet weekly to review what's happening in schools. We're monitoring absenteeism, and schools remain a supportive, inclusive environments where masks are available in every class and where it is accepted and encouraged to wear a mask whenever people feel they need to. But I think we all need to recognize we are all human, and masks are protective equipment, but they're only as effective as we make them. And that can be a challenge, especially for children sometimes. And I do not believe we need that heavy hand of a mandate to send a clear message that masks are an important tool that we can all use during this time and in every respiratory season. We should have one with us. We should use it in situations where it makes sense. And it may differ depending on the situation. I think about it, I may wear a mask one day on the bus if it's crowded, the windows are closed, or if I'm worried that I might be getting the sniffles. But on another day, if I'm feeling fine and there's lots of space and good ventilation, I may choose not to, and that's okay. I think those are the decisions we have to bring masks in as a tool that we can use when it's appropriate, when it's necessary. If I have a sick child at home, I may wear a mask in my workplace to be extra cautious, even though I'm feeling well and I need to go and I can go into work. Or I may participate in a meeting where there's more people in a crowded setting remotely rather than in person. The settings where masking continues to be essential are in healthcare settings. And we have a mandate in all of our healthcare settings across this province at all times. These tools are necessary all the time. So we have vaccination requirements for healthcare workers across our healthcare settings in this province, and everybody in long-term care, hospitals, vaccination clinics, community clinics wears masks throughout this respiratory season. These are important additional measures in those places where it matters the most. And additional measures we have in long-term care are including that residents are protected through testing and ensuring visitors are also vaccinated. All of these are important, but our best protection remains protecting us from getting infected in the first place through immunization. And as we can see, we have very high rates of immunization and high rates of boosters, protecting people, particularly at older age, but we have work to do for younger children. So I encourage everybody, now's the time to make that appointment. You can get your influenza vaccination, your COVID booster at the same time. As well, as I mentioned, there's nasal flu shots for children, and flu vaccines are available to everyone 6 months of age and older. The other thing that is different this year is that we have enhanced influenza vaccines for all seniors over the age of 65, and those give additional protection against influenza than the standard dose vaccines because they stimulate a stronger immune response. So I encourage everyone to register and book your appointment for your flu shot and your fall booster now. All right. So as we are going through the respiratory season, and as I mentioned, we knew that this was coming, and we've been preparing for this as best we can, and the things that we all do together collectively now will make a difference as we get through this next few months. As we all look forward to the holiday season as well, it's important to keep our personal toolkit handy. We have many tools that can help protect us, our loved ones, our community from all of these viruses that are circulating now. First and foremost is getting vaccinated, but also having a mask with you, wearing it in those crowded indoor settings, wearing it when you're not sure if you have the sniffles or not, doing that health check every day for yourself and your children, avoiding touching your face and eyes and nose, using respiratory etiquette, coughing in your sneeze, covering your cough, disposing of your tissues, remembering your hand hygiene. You can also choose where you gather and when you gather with friends and family, looking for open spaces with good airflow, looking at postponing some of those visits if there's illness in the family. Regularly cleaning surfaces, paying attention to ventilation. And if you're feeling unwell, stay home and avoid contact with others, especially people who may be more at risk. I want to thank everybody in British Columbia for their continued commitment, and we've seen this all along, of recognizing that we're all coming from different places and that we need to be supportive of each other. If you're wearing a mask today, given the situation that you're in, we need to be supportive of that too. And that means this is how we're going together to get through this respiratory season and practice, get it, be part of how we do this every year, as we know that these viruses are going to be coming around again. Thank you. I'll turn it back to Minister Dix.
Thank you, Dr. Henry. Dr. Henry's leaving me with a clicker, which is a high show. Oh, you're going to, yeah, only one person has the clicker here. So, thank you, Dr. Henry. Just going to go on with a presentation with respect to current hospitalization status, where we are, and where we expect to be. In September, we said that we had to prepare our hospitals for respiratory illness season and a possible surge in patients. Our hospitals have well-established systems in place to manage high patient volumes, including regional and provincial surge plans. They've been planning for various scenarios and are ready to respond to an influx of patients requiring care for respiratory illnesses. Plans are in place. And fortunately, in large measure, we are not at a point where we need to implement them yet, but we're ready if we need to. Our readiness plans include improving and increasing hospital bed capacity and emergency department efficiency. We go on to the next slide, which I think is this one. No, it's back one now. We're still on that one, yeah. In terms of capacity, in October, COVID-19 hospitalizations, as Dr. Henry has said, were down, but they're relatively similar to September levels. Hospital occupancy is up from September, rising by 1 point to 95.4% of base bed capacity. And when we include surge beds in those numbers, the occupancy increase to this point in November is 2.2%. We see that reflected in that slide. There's a lot of interest in children's critical care capacity. I would note that this changes, and as you can see, can change significantly from day to day, because overall in the province we have amongst children's high acuity beds and neonatal intensive care beds, we have 243 beds, but a change of 1 or 2 can very significantly change the information at each site. For example, on Monday, there was an overcapacity at Kelowna General Hospital. Today, we are under capacity for that because there's a small number of beds, and the reduction or 2 or 3 can significantly change those numbers. The pediatric ICU rates tend to change more, of course, as we've said, but essentially we are at, as of today, as of yesterday, it was 67%. I think we reported that in our children's critical care beds today at 64%. In terms of our children's high acuity units, it's up slightly from 74 to 76 from yesterday to today, to give you a sense of the day-to-day changes. The next slide, please. You see in terms of emergency department visits, over the last period, we have seen an increase overall in November on average from where we were in September and October. In September and October, it was roughly 6,700 visits a day. In November, that number is up to 6,765. Understanding that at different sites, that can be a varied amount on different days. Next slide, please. In terms of bed management, our emergency department and hospital capacity task group is integrating priority actions into health authority surge response plans. These plans include improving emergency department triage processes to better and more quickly connect patients with community care to avoid or shorten hospital stays. They also include hiring more patient care coordinators to improve the flow of patients through hospitals and heightening integration with urgent and primary care centers, and strengthening communications to patients, as well as ensuring support to rural and remote care, and all of the investments we've made in patient transport. Next slide. Pediatric, in terms of pediatric ICUs, we have a dedicated provincial pediatric team that coordinates our pediatric resources. We have pediatric ICUs, of course, located at BC Children's, Victoria General, and the University of Northern British Columbia, and neonatal ICU beds in many jurisdictions and many hospitals across the province. This dedicated team is focused on a daily basis on what's at stake and responding to the demands of respiratory illness season. And so you see that, and you see that in the response specifically at that care and some of the numbers I spoke about just a few minutes ago. If we move on to the next slide, please. In terms of increasing our capacity in community, this was a part of our plans, and that means something in a term which I'll explain. It's called alternate level of care, or ALC patients. Essentially, those are patients who are in hospital but are really ready or should be in long-term care. And they're being provided hospital care as they either wait for a long-term care transfer in an available bed. And that is one of the ways that we measure patient flow in the system, and also it's a possible place where you can create capacity in the system by creating more access to long-term care beds in the community. And that's precisely what we've been doing. We've seen in October a reduction of ALC patients as a percentage of occupied beds that is decreased. And we have specific measures that we've put in place, including the opening of beds to ensure that we're ready as we need to address potential demands on capacity from respiratory illness season. So we're adding beds across all health authorities in long-term care to allow for more space in acute care. This is not an issue of moving acute care patients to long-term care. It's a case of patients who are long-term care patients but in acute care moving over to long-term care and creating capacity at a time when there are capacity pressures in the system. And there's lots of details by health authorities, and you all have the PowerPoint, and I'll let you go through those. And the next slide, I think. That's it. Yep. Just to say finally that, we're opening long-term care beds, and we're supporting operators of long-term care beds who are often health authorities or often private for-profit or non-profit providers, including staffing float teams and virtual nursing services, and providing casual staff with more flexible opportunities for regular part-time and full-time work. We're implementing strategies for patients who can be supported at home, including providing casual staff opportunities for regular full-time and part-time work, adding capacity in home support and in adult day programs, and ensuring quicker access to transitional care for complex patients discharged from the hospitals. Our hospitals need to be ready And as you can see from Dr. Henry's presentation, we need to continue to be ready as we go through this season. We are behind, thankfully, other jurisdictions in the country in terms of these pressures, but we need to prepare for them. And we all finally, with those plans in place, need to do our part. We need to be ready too. We need to get vaccinated. We need to wear a mask, especially if we have mild symptoms. We need to stay home if we're sick, and we need to wash our hands frequently. And we need to keep doing what we know, because what we know works.